All right, ladies and gentlemen, here's the continuation of our lecture. We're going to pick right up with colloids and crystalloids. There's two major classes of IV fluids, and these are, as I said, called colloids and crystalloids that you will find both in the body as well as within specific IV fluids also. Colloids contain compounds of high molecular weight, usually proteins, which do not readily diffuse across the cell membrane. In addition, they also exert colloid osmotic pressure, which means that they tend to attract water into the intravascular space. Now, question here is, when it attracts the water into the space, what does that do to the blood pressure? Does it cause it to go up or does it cause it to go down? Well, if you said it causes it to go up, you are correct. Thus, a small amount of colloid can be administered to a patient with a greater than expected increase in the intravascular volume. Again, this is because the colloid will draw water from the interstitial space and the intracellular compartment to increase the intravascular volume. Common examples of colloids include the following: plasma protein fraction, also known as plasminate. Plasminate is a protein containing colloid. The principal protein present is albumin, which is suspended along with other proteins in a saline solution. Albumin infusions contain only human albumin. Each gram of albumin holds about 18 milliliters of water within the bloodstream. Crystalloids now, they contain only water and electrolytes. These substances readily diffuse across the cell membrane. Crystalloids are the primary solutions and used in pre-hospital IV fluid therapy. Most commonly, what you will see is going to be normal saline and lactated ringers. Because there's multiple fluid preparations, it's often helpful to classify them according to how concentrated they are as related to plasma. Now, let's talk about isotonic solutions. Isotonic solutions have an electrolyte composition that is similar to that of blood plasma. When placed into a normally hydrated patient, they don't cause a significant fluid or electrolyte shift into or out of the cell. Hypertonic solutions, on the other hand, hypertonic, have a higher solute concentration than does plasma. These fluids tend to cause a fluid shift out of the intracellular compartment into the extracellular compartment when administered to a patient that is hydrated at a normal level. Hypotonic solutions have a less of a solute concentration than does plasma. When administered to normally hydrated patients, they cause a movement of fluid from the extracellular compartment into the intracellular compartment. Later, solutes move in an opposite direction. So, let's take a look at specific types of IV solutions. First, we're going to look at lactated ringer solution. It's classified as an isotonic crystalloid solution. Lactated ringers, or more commonly known as LR, is one of the most frequently used IV fluids in the management of hypovolemic shock. It's an isotonic crystalloid solution that contains electrolytes of sodium, potassium, calcium, chloride, and you don't really need to know the amounts because it's not really going to be that important to you, but you do need to know the electrolytes that are contained in there. In addition to the electrolytes that we just talked about, lactated ringer solution contains lactate in the form of lactic acid, which acts as a buffer. Now, how does it work? The mechanism of action. Lactated ringers replaces water and electrolytes. It most closely resembles normal body fluids in terms of electrical composition. It is indicated for patients who are having moderate to severe hypovolemic shock, burns, and the way that we would do this is we can always just keep the vein open, which basically is just keeping just enough fluid going to be able to administer fluid through that or medication through that line, or we can speed up the process of the administration. Now, Lactated ringers shouldn't be used in patients with congestive heart failure or in renal failure. Anytime that we're giving a patient lactated ringers, watch them closely to prevent circulatory overload. And the way that we identify circulatory overload is going to be by way of listening to breath sounds and listening for crackles or fluid in the lungs. There really aren't that many side effects in the pre-hospital situation if we are using it correctly and if we're watching for the potential for a fluid overload in our patients. Crystalloids such as LR solution diffuse out of the intravascular space and into the surrounding tissues in less than an hour. Because of this, it's often necessary to replace 1 liter of lost blood with 3 to 4 liters of lactated ringer solution. So kind of keep this in mind because we will definitely focus on this as we're going into trauma of this movement of a 1 to 3 replacement ratio of blood with fluid that gets lost. If hypovolemic shock is severe enough, LR solution should be infused through a very large IV cannula. Now, these infusions can be administered wide open or as fast as the fluid will go in until we get a systolic blood pressure of about 90. Now, we don't want anything higher than 90 to 100 as far as the blood pressure. That's the top number of the blood pressure because in hemorrhagic shock, the clots are very, very fragile. And if we raise the blood pressure up too much, we're going to basically blow those out and cause our patient to start bleeding again. When we get that blood pressure of between 90 and 100, and we want to check it probably about every 5 minutes, we should change the infusion over to about 100 milliliters per hour just to watch and maintain that pressure. If the pressure falls, then we'll open the infusion rate back up, just like we did before, and watch the blood pressure. So the route that we're going to do this is we're going to obviously give it IV. And as far as how it's supplied now, LR, like most all IV solutions, comes in 250, 500, and 1,000 milliliter bags and bottles. You will only use bags for your crystalloid IV solutions on the ambulance. Again, just as a reminder, you may see it referred to as 250 milliliters or 250 cc's. Each one of those equals the same thing, and they are interchangeable. When aggressive fluid replacement is not indicated, 5% dextrose in water, also known as D5W or just simply D5, may be used. D5 can be used for the administration of IV medications. Now, D5 is hypotonic, which prevents circulatory overload in patients with heart failure. As far as the mechanism of action, D5 provides nutrients in the form of dextrose as well as free water, which makes up the majority of the composition of it. What we're going to use D5 for is for the dilution of concentrated medications for IV infusion. Now, keep in mind that D5 should not be used as fluid replacement if your patient is bleeding. Dextrose-containing solutions should also be avoided in patients with head injury or stroke, as they can rapidly pull fluid off of the brain, leading to more neurological problems. Dextrose-containing solutions are acidic and may produce local venous irritation. Be careful and watch to make sure that if it infiltrates or it begins to blow and it goes into the tissue, known as infiltration, it may result in death of tissue, also known as necrosis. As with any other IV fluid, make sure you're watching for circulatory overload by listening to the breath sounds early and often. When we're treating hypoglycemia, it's imperative that a tube of blood be drawn prior to giving D5 or any other concentration of dextrose to our patient. Not a lot of side effects when we're giving it in the correct doses. Now, we can have a negative medication interaction when it is used with Dilantin, which is a seizure medicine, or Inacor, which is a medicine that's used to raise the blood pressure. D5 is usually administered through what's called a mini drip. We'll talk more about that a little bit later on, and set at a rate to just simply keep the vein open, also known as KVO or TKO. Again, D5 is supplied in the same sizes of bags and bottles as we did see with lactated ringers. It will go down to 50, go up to 100, all the way up to 1,000 milliliters. The use of 0.9% sodium chloride, or what is called normal saline, or just simply saline, has several applications in emergency medicine. Normal saline is made up of sodium and chloride ions. Because the concentration of sodium is pretty close to near that of the blood, the solution is considered to be isotonic or normal. Normal saline is especially useful in heat stroke, heat exhaustion, and diabetic ketoacidosis. NS will replace water and the electrolytes of sodium and chloride. Why do we want to use it? Again, it is helpful for heat-related problems, as we talked about just a little bit ago, as well as in the patient that has a history of diabetic ketoacidosis. The use of 0.9% sodium chloride should not be considered in patients with heart failure because it again can cause overload. And it's correct, boys and girls, I'm going to tell you to listen to their breath sounds. That's going to be critically important. Now, when large amounts of normal saline are administered, it's quite possible for them to help to pull out some of the other electrolytes to become diminished. Probably not going to be much of a problem for you and I because we're going to be with these patients for a relatively short period of time. But that is something to kind of keep in mind should you decide that you're going to work in a hospital where they may be on this fluid for quite a while. In cases where large amounts of fluids may have to be administered, it's better to use lactated ringer solution for a number of reasons. One, there are more electrolytes in it. And number two, it's buffered, which means it's going to be less acidic than is sodium chloride. Patients that are in shock, especially patients that have hemorrhagic shock, will not clot well if their pH slides over to the acidic side. Not a lot of side effects in this, especially if we're using it in the correct dosage. Now, as far as the amount that we give, the specific situation being treated dictates the rate at which normal saline is going to be administered. So if we got a patient that's bleeding and we got a really low blood pressure, we bring that up. And again, remember, this is critical. That blood pressure target that we're looking at is 90 to 100 systolic. In severe heat stroke, diabetic ketoacidosis, and freshwater drowning, it's quite likely that you'll be called upon to administer the fluid quite rapidly. In other cases, you may want to give it at a much slower rate. It is given as an IV infusion, and again, it is supplied just like lactated ringers in 250, 500, and milliliter bags and bottles. Now, here's the thing to remember. Sterile normal saline for irrigation should not be confused with that is designed for IV administration of medications. Those are two entirely different concentrations of saline. So, how do you know what to use? Which flavor of IV drug do you use? Well, usually the decision of the type of IV fluid to use is written in your protocols. It's important to be familiar with the types of fluids that have been discussed in this particular lecture. Now, there's two general types of IV administration sets. One is called a macro drip, or the standard set. And basically what it does is it delivers that for every drop, every 10 to 20 drops that comes down, and that's specific to the set, it equals 1 milliliter. So this is helpful when we're manually calculating a drip rate. If a larger quantity of fluids is to be administered, then you need to use a macro drip set. Whenever you're going to administer medication through the IV, you will almost always use a mini drip set. Now, this is especially true for what are known as piggyback medication infusions. Many systems use flow control devices, or thankfully, we're getting to see more and more electronic pumps in the ambulance for giving different types of medications. If these sets are used, the paramedics should remember them when they're preparing to administer any kinds of IV medicines. So the question is, and you'll learn more about IVs when you get into the actual IV placement, when you get into the advanced sequence. But where do we start our IVs? Well, routinely IV infusions should be started in the larger veins of the forearm, primarily because these are the easiest to access and they're the least painful for the patient. Now, many times these veins are not available. So we see it often in shock and trauma, and then we'll take any vein that we can potentially get. The veins of the leg and the external jugular vein of the neck are considered peripheral veins. We have peripheral and we have central veins. When treating medical or traumatic emergencies, the rule of thumb for getting an IV started is any port in a storm. In cardiac or traumatic arrest, the antecubital vein is the preferred site. Now, the thing to keep in mind is that every medication and therapy that you're going to do for your patient has potential complications, and the same is true for IV therapy. Complications of IV therapy include infiltration, where basically the fluid infiltrates into the tissue, as you can see in the lower right-hand corner of this particular graphic here. It's just kind of coming, the IV catheter has gone through the vein, and now we're just kind of spilling it out into the tissue. We can get catheter shear. Catheters that are over the top of the IV are made of plastic, or of Teflon, not plastic. And by sliding them back and forth on the needle, it's possible to shear off or shave off small pieces of that catheter so that now it becomes part of the circulatory system. Patient can develop phlebitis. Phlebitis is an inflammation of the vascular system, and usually generally of the vein. Very painful and very difficult to treat. The most troublesome IV complication we talked about a little bit ago is infiltration. And again, infiltration happens when the tip of the catheter becomes dislodged from the lumen, or the inside part of the vein. The fluid of the medication then is delivered to the soft tissues around the vein. Infiltration of medicines into the soft tissues can result in tissue destruction and necrosis at the site of infiltration. In particular, we're looking at drugs that are high percentage dextrose and other drugs such as dopamine that can literally cause the tissue to rot away. So we want to watch that really, really closely. Infiltration of an IV line can be suspected when the fluid no longer freely drips. Other signs of an IV line infiltration include pain and swelling at the IV site. Often, the only treatment that you need to do for any type of just a plain IV that is infiltrated is just to simply discontinue or DC the IV line and get a new line started either proximal or above the infiltration site, or in a completely different extremity that has not been injured. Infiltration of a large amount of fluids in areas such as the hand and foot can cause pressure changes to the underlying adjacent structures. Infiltration in these areas should be treated by the elevation of the affected area to allow the fluid to begin to dissipate, and to do multiple exams to check to make sure that the vasculature, the motor, and the sensory function of the patient is still intact. When we talk about vascular, we're talking about checking for distal pulses. Motor, can the patient move their fingers and their toes? And then sensory, having the patient close their eyes or move away, can they tell which finger or which toe that you are actually touching? If medication infiltration is suspected, document findings about the site, the time of the incident, and any treatment that you may have rendered. Many medications and electrolytes that can cause vasoconstriction require injection of the medication into the infiltrated site. We got to watch them really, really closely, and potentially, if the tissue begins to necrose or rot, they may have to go into surgery to have it debrided and have reconstruction made. As I said a while ago, catheter shear is a complication that occurs when a segment of the catheter, again made up of Teflon, breaks off and is either retained in the vein, it just kind of stays there, or even worse, now becomes an embolus and begins to travel through the venous system. This complication can occur when a provider attempts to pull the catheter back over the needle. The solution for that is don't do it. This typically occurs when blood return appears while starting an IV. While attempting to advance the catheter into the vein over the needle, the provider either encounters resistance or loses the blood return, and then tries to save the IV line by pulling the catheter back over the needle. After advancing the catheter follows the course of the vein, which is at an angle from the needle. When the provider pulls the catheter back over the straight needle, the tip of the needle can cut the catheter into two pieces. The severed part of the IV catheter can remain at the site of the attempted IV start. The severed IV catheter can also float away in the vein to a site that's more proximal into the lung, or even to the heart, into the lungs, or into the brain. If it goes into the heart, the patient has a heart attack. If it goes into the lung, they develop a pulmonary embolus. If it goes to the brain, our patient has a stroke. Sheared catheters can require surgery in order to go back in and to be able to get them out. If shearing of an IV catheter is suspected, make sure you notify medical direction as soon as you can and document the communication. Make sure that if you mess up and you do something wrong, that you are truly going in and you're telling somebody about it so that it can be fixed. Yes, there will most likely be consequences that will have to be meted out. But again, the consequences will be much less than if you didn't tell somebody, the patient dies, and then later on they find out about it. Potentially, those consequences could wind up in criminal charges. Less immediate complications of IV lines include, like we said, infection as well as just simply pain around the injection site. None of these infectious complications will become apparent to you who start the IV line in the pre-hospital setting. They'll typically develop several hours or days later. The key here is to use as aseptic or without contamination technique as you possibly can. We work in a dirty environment in pre-hospital medicine, and so it's going to be really important that you try when you're doing any type of invasive procedure, such as giving an IM, an IV, or a sub-Q injection, that you do it as cleanly and safely as you possibly can. Now, by using as sterile a technique as you can, this will help to reduce the incidence of these types of complications that we just spoke about. IV lines that we start in the field are often started in less than optimal conditions and sometimes in really, really dirty conditions. But again, we have to treat what's going to kill our patient first. For this reason, when you get to the hospital, don't be offended if the hospital takes your line out and starts a brand new one. Again, they're trying to minimize any kind of infection that the patient may come about with. Now, we mentioned a while ago what phlebitis as far as a complication. So exactly what is this? Phlebitis, also spelled Phlebitis, is an inflammation of the vein that can manifest as pain, redness, and edema. There's many different conditions that can irritate the vein and cause the inflammation of phlebitis, including giving concentrated fluids and certain electrolyte fluids, various medications, and just simply the presence of having a plastic catheter or a Teflon catheter in the lumen of the vein. When phlebitis causes the blood inside of the lumen to begin to clot, the condition is now known as thrombophlebitis. When a patient has thrombophlebitis, he or she can often feel the thrombosed vein along the length of the thrombosis or the clot, and palpation of the vein elicits tenderness and pain for our patient. On occasion, thrombophlebitis can become infected. Supportive thrombophlebitis occurs when the clot of the thrombophlebitis now itself becomes infected. This is a potentially fatal condition for our patient. The treatment for this type of thrombophlebitis is to go into surgery, and they will open up the vein, and they will either take that section of the vein out and resuture it back together, or they'll simply go in and remove that particular clot to get it out. When mismatched blood is transfused, the donor's antibodies can bind to antigens on the recipient's red blood cells. This reaction is known as a transfusion reaction, causes a clumping of the red blood cells in the blood. This is also known as agglutination and subsequent hemolysis or breakdown of the red blood cells. They basically begin to swell up and rupture. Transfusion reaction can be prevented only by complete and careful tight matching between the donor and the recipient. Now, you're going to be carrying patients who are getting blood products. These patients need to be watched closely for signs and symptoms of a transfusion reaction. That can happen hours after the blood replacement has started. The severity of the reaction depends on the degree of incompatibility, the amount of blood given, and the rate of administration. Onset is usually rapid, but it typically happens during or immediately after a transfusion that has been started or ended. More rarely, it will occur hours later, but it can occur. Signs and symptoms, and you need to know these, of a transfusion reaction include anxiety, facial flushing, pain in the neck, chest, and the lumbar area of the back, the very lower back, tachycardia, cold, clammy skin, hypotension or a drop in the blood pressure, nausea and vomiting, dizziness, hives or raised areas on the skin, also known as urticaria, Ruticaria, headaches, and a fever. Now, when these signs and symptoms of the transfusion reaction appear, you've got to stop that transfusion right away. We'll teach you how to do that in the lab when you get into the sequence. A crystalloid solution for medication administrations needs to be maintained. And generally what we're going to do is we'll give them a fluid bolus. A bolus simply means a large amount of fluid that we're going to administer to help make sure that we've got good urine protection. Often we can give a diuretic such as furosemide, also known as Lasix, that will increase urine production, as well as an antihistamine such as diphenhydramine or Benadryl may be given to treat this. In essence, it's a type of an allergic reaction. One of the most lethal effects of transfusion reaction is renal failure, which can begin within a few minutes to a few hours and could potentially progress to death if the renal failure is rapid enough. So as we conclude this one out and finish this one off, it's important for you to understand and to go back and to read your material and make sure that you have this very brief knowledge of IV fluids, what their roles are, as well as what their limitations and some of the signs and symptoms of a transfusion reaction. Don't hesitate to contact me if you have any questions or if I can do anything to help you with this particular part of the lecture.